Hello everybody, my name is Bradley King, a fourth year medical student at UCSD, and today I'll be sharing our group's research on an expedited outpatient pathway for gastrostomy tube placement in patients with head and neck cancer. Image-guided gastrostomy tube, or G-tube placement, is often indicated in patients with head and neck cancer in order to provide nutritional support. Conventionally, patients are admitted overnight for observation, but the safety profile and outcomes compared to outpatient placement is relatively unknown, with only isolated studies showing similar complication rates. Our study goal was to implement an expedited outpatient pathway for G-tube placement at our institution, comparing outcomes to an analogous inpatient population in order to assess the safety and efficacy of outpatient placement. Patients in the outpatient pathway first underwent pre-procedural consultation with a head and neck surgeon, home health worker, and dietitian in order to evaluate for the risk of refeeding syndrome and receive education regarding the care and management of their tube. Following this appointment, patients underwent G-tube placement by interventional radiology, and following a brief period of observation were discharged the same day. The following day, patients were contacted by telephone in order to assess for complications. The 30-day outcomes of this cohort were tracked and retrospectively compared to patients admitted overnight during the same time period. The rationale for outpatient G-tube placement was multifactorial, but included the overall goal of reducing hospital stays and associated costs, initiating feeds sooner, decreasing outpatient clinic visits, and improving communication between the interventional radiology and head and neck teams. During the study period, 46 patients underwent outpatient G-tube placement, while 32 were admitted overnight. The two groups were similar in terms of age, sex, number of gastropexy sutures used, and the frequency of use of enteric barium. Tube type and tube size differed significantly amongst the two groups, reflecting a change in practice pattern at our institution from smaller pigtail type tubes to balloon retention type tubes. G-tube placement was technically successful in all patients and no major complications were encountered. More minor complications, including leakage, cellulitis, tube dislodgement, pain requiring admission, and vomiting and delayed first feed of greater than 2 days were similar amongst the two groups. Notably, the time to initiation of tube feeds following the initial IR consult was faster in patients undergoing outpatient placement, with a delay of 11.8 days versus 16.3 days in patients undergoing inpatient placement. In summary, expedited outpatient G-tube placement is safe and effective in select patients with head and neck cancer, with no major complications observed and comparable minor complications to inpatient placement. In our study, outpatient placement was associated with faster initiation of tube feeds, and carries the intrinsic benefits of decreased admission rates and improved interdisciplinary workflow between the interventional radiology and head and neck cancer teams. Larger prospective studies are warranted to validate these results and confirm the safety of outpatient G-tube placement.